As per the latest guideline of NMC, this seminar SGL and SDL, everywhere there is 2 marks each. So যারা পার্টিসিপেট করছো তারা কিন্তু এই 2 নম্বর পেয়ে যাবে, যারা করছো না তারা পাবে না। ওই জন্য আমি তোমাদের বলেছিলাম যে যা খুশি বলো কিন্তু পার্টিসিপেট করো। This is required as per the new CBME guideline by NMC. This is required. Anyway, so our today's discussion is on enterococci and pneumococci. From the name enterococcus, you can easily understand that entero means intestine. Entero means intestine and coccus is round and usually gram positive spherical microorganism. So this particular group enterococcus, as per the classification, I must say the clinical classification of streptococcus, there are so many classifications starting from Sherman's classification to molecular classification of streptococcus. This last one, or clinical classification, is easier to understand as this classification is on the basis of hemolysis. Hemolysis on blood agar medium. So 3 types of hemolysis usually we know, that is alpha hemolysis, beta hemolysis and gamma hemolysis. Alpha hemolysis means partial hemolysis, beta hemolysis means complete hemolysis and gamma hemolysis is no hemolysis. So if the group is alpha hemolysis, alpha, beta and gamma. Alpha hemolysis, the next question on alpha hemolysis is how you are going to differentiate between the different species of alpha hemolytic group. The example of alpha hemolysis, as you know from your earlier classes, is streptoviridans and pneumococcus, that is Streptococcus pneumoniae. Now, how to differentiate between these two? One simple test is there, known as optokine test, optokine sensitivity test, optokine sensitivity test, by which you can differentiate these two. Optokine is positive for pneumococcus, negative for Streptococcus viridans group. Is it clear? In case of beta hemolysis group, which was classified by Rebecca Lansfield on the basis of C carbohydrate. So C carbohydrate protein, on the basis of this C carbohydrate protein, Rebecca Lansfield classified Streptococcus beta hemolysis group into 20 types, starting from A to excepting I and J. So 20 type except I and J. Why? Because I at that time international unit starts with the word I and J stand for journal. That's why at that time Rebecca deleted these two from the classification. So excepting I and J, all are included in the group of this classification. Now this beta hemolytic group is classified on the basis of C carbohydrate antigen. Then gamma. The classification on the different species is very easy, depending on how they can withstand 6.5% sodium chloride. particular group, a particular serotype can withstand this 6.5% sodium chloride is called enterococci, our discussion of enterococci today. So they can withstand 6.5% sodium chloride. And then another group, they are non-enterococcal group. Non-enterococcal group. So easily, now you will be able to separate out these all groups of alpha, beta and gamma hemolysis. Now, the enterococci, they are typically diplococci in nature. They are gram-positive diplococci. Two types of gram-positive diplococci we usually found in our clinical specimen. One is oval, leaf-like and gram-positive. Some are arranged in chain because it is in the group of streptococci. Their division in straight plane, cell division in straight plane. So, diplococci as well as straight chain. It is sure that this is enterococci. This is characteristics of enterococci. In pneumococci, the capsulated variety of gram-positive diplococci is lanceolate shaped, flame shaped. The upper portion is like flame. The base facing each other, flat, and it is capsulated in nature. It is gram-positive. So, gram-positive, capsulated, lanceolate shaped organism is pneumococcus. And gram-positive, oval, facing each other, also organisms, gram-positive cocci in straight chain, classical examples of enterococci. Enterococci, they are usually seen in intestinal tract. But this enterococci, they are really virulent. We often encounter two particular type of enterococci. One is enterococci fecalis, another one is faecium. The fecalis is usually common and faecium is highly drug resistant. To treat the enterococci group of organism is a real challenge in our clinical practice. These particular enterococci, they often share the property of producing biofilm. They invite other organisms to be the member of their biofilm and can transfer the drug resistancy among the different groups. As they are highly resistant, they can share by different methods of gene transfer the different drug resistant gene to other species. And thus, the group is highly drug resistant. What is the importance of that? The biofilm usually is produced on the catheter, on the surface of the catheter, the inner surface of the catheter. So those catheter, those are used practically in cardiovascular surgery, in urinary tract infection, in other severe diseases, stent. Everywhere there is a real challenge, real threat of developing these particular biofilm. Enterococcus can enter the circulatory system by the intestinal tract because they are present there in the intestinal tract. So any surgery related to our intestinal tract is really challenging. From that particular site, organism can propagate through the blood system, blood circulatory system to our different organ. So it can produce endocarditis when it enters heart. In case of previously damaged heart, where there is a minimum damage, they produce vegetation, a hanging projection or clump of organism. This particular vegetation is really challenging, really dangerous, fatal for the patient. So mitral vegetation, mitral valve, aortic valve vegetation is really dangerous. And that particular infection is precipitated out from the different site of the alimentary tract as well as from respiratory tract. The infections, we can classify these enterococcal group of infection into invasive group and non-invasive group. From non-invasive group, the usual infections usually occurs in as otitis media or skin infections, etc. And from there, it can propagate through the blood, hematogenous route to the different system. And endocarditis is really life-threatening. So, to treat this particular enterococcus group is a challenge. And enterococcus, it transmits the drug resistance by another important mechanism is known as transposon. The jumping gene, it has certain resistance which are called intrinsic resistance. That means they are genetically resistant to certain group of antibiotics. They are genetically resistant to certain antibiotics from the very beginning, from their birth. What are they? They are resistant to oxacillin, resistant to penicillin, resistant to amoxicillin, resistant to cephalexin group, and a variable group of resistance among aminoglycosides antibiotics like streptomycin, like gentamicin and netilmycin and other groups. Variable resistance means if in sensitivity test we find the organism is sensitive to streptomycin, don't think that it will be resistant to all the aminoglycosides. In case of the other members of this group, they may be sensitive. And a high level gentamicin resistance, a high level streptomycin resistance exists among them. Why I am going to mention this particular terminology, high level gentamicin and high level streptomycin? Because in case of endocarditis, you are going to prescribe a cell wall antibiotic combined with an aminoglycoside antibiotic as a life-saving measure. In spite of it is intrinsically resistant to cephalosporin group. Even though it is intrinsically resistant to cephalosporin group, you are going to add gentamicin or streptomycin if the high level gentamicin or high level sensitivity is there during the sensitivity procedure. So here we use a particular disc that is known as high level gentamicin, that is known as high level streptomycin, and by which we particularly enters into a point of treatment where synergism is the key to cure the infective endocarditis, a life-threatening disorder, and where the treatment is immediately required. So, the sensitivity test here is very important, and here the high level gentamicin and high level streptomycin sensitivity test is a must. So, by which we can understand the synergism of different drugs, a cell wall antibiotic with another antibiotic which is not acting on the cell wall, acting on the GNA or RNA of the bacteria, combining two simultaneously. So, drug synergism is important to treat enterococcal disease, especially endocarditis. So far as vancomycin is concerned, in MRSA, methicillin resistant drug resistancy, MRSA, where methicillin is resistant, that means ampicillin group is resistant, cephalosporin group resistant, at least first, second and third generation. The drug of choice is vancomycin. Enterococcus is highly resistant to vancomycin, but not all. There is a mechanism of drug resistancy in Enterococcus by this transposon, which is known as VAN A, VAN B, VAN C, VAN D, VAN E. Some are resistant to vancomycin, sensitive to teicoplanin. Some are high level resistant to vancomycin and low level sensitive to teicoplanin. There may be a permutation combinations between vancomycin and teicoplanin of the same group. So, you can understand that it is a real challenge for the clinician to treat any case where Enterococcus is the diagnosis. So, enterococcal endocarditis is a short note, and to write enterococcal endocarditis or infective endocarditis, please include this enterococcal group, and any hospital infection you deal, this enterococcus discussion on enterococcus drug resistancy is must. Now, coming to pneumococcus, a respiratory tract infection is produced by pneumococcus. From the name pneumo, the site of infection is chest, isn't it? Pneumonia, maybe lobar pneumonia, maybe bronchopneumonia, and otitis media, subsequently meningitis, subsequently sepsis may be precipitated out. The pneumococcus is capsulated. The gram-positive organism which is capsulated, the capsule is polysaccharide in nature. Almost all the capsules are polysaccharide in nature except one. Can you name the bacteria? You will read later on. Bacillus. Bacillus, a particular organism where the outer capsule is protein in nature. So, everywhere there is polysaccharide. The capsule is polysaccharide in nature. And this particular polysaccharide capsule is also called SSS, a super soluble substance which clearly enters inside the media. This SSS, the capsular polysaccharide, is not T cell dependent. From my class on immunology, this polysaccharide antigen can directly stimulate B cells, and can produce immune response. That is plasma cells, and from plasma cells and to memory cells and even immunoglobulins. So, this is polysaccharide in nature and can provoke B cell response. And this B cell response as it is polysaccharide in nature, the stimulus, the immunogenicity is less. It is not protein in nature, no adjuvant is there, so immune response is not much. So this particular polysaccharide and any vaccine prepared out of this polysaccharide, as it is an antigen of the organism, is not going to elicit long time response. Is it clear? Polysaccharide in nature directly involve the B cell, C-reactive protein is used. Pneumococcus, for lab diagnosis, you have to collect the sputum specimen of this patient, and from the sputum you have to identify the capsulated lanceolate shaped organism which will be gram positive. And if you go for culture, your media of choice will be blood agar media or chocolate agar media, and where in blood agar media it will show pneumococcus alpha hemolysis, and a green type of color is seen in case of alpha hemolysis. We don't know the reason of that, but a greenish discoloration is seen surrounding the colonies. Now this pneumococcus is particularly autolytic. They can destroy their own colony. They have a particular type of antigen, an enzyme rather, is known as amidase. That amidase, if we can stimulate this amidase by adding something, especially bile salt, the amidase is stimulated and the cell binding protein peptidoglycan are lysed, and there will be an autolysis. So in a media where pneumococcus is grown, we add 2% of bile salt, and within 10 minutes there is no colony. This particular property of pneumococcus due to amidase enzyme is known as autolytic property of pneumococcus. Pneumococcus is also optokine positive. A particular disc of 6 microgram, if we put on the culture plate, there will be sensitivity surrounding the disc at least more than 14 millimeter. This is optokine sensitivity test. And any fermentation reaction of pneumococcus is performed in a particular serum known as His serum protein. In His serum protein, the fermentation reaction for inulin is positive, glucose is positive, sucrose is positive. So these are the biochemical tests of pneumococcus, and for the lab diagnosis, the culture, the particular property of pneumococcus of alpha hemolysis, followed by this optokine sensitivity test, inulin fermentation test, and the bile solubility test will be able to identify pneumococcus. And other methods are of course there. Those are molecular based, PCR and etc. So this is all about pneumococcus. The most important thing is that the pneumococcus may be a common cell, and whenever the immunity of a patient goes down following HIV, following any respiratory tract infection, any viral infection, or transplant, or taking oral corticosteroid, or simple viral fever, there is a possibility of flare-up of this particular group, again from the respiratory tract. So, they are opportunistic as well. They often produce the nasal blockage, tympanic membrane obstructions, pharyngotympanic tube block. Following respiratory tract infection, you can remember that what happens to us? Respiratory tract infection following nasal blockage. নাক বন্ধ হয়ে গেছে, কানটা বন্ধ হয়ে গেছে, মাঝে মাঝে ফট করে খুলে গেল, হা করলাম খুলে গেল. The culprit is pneumococcus. They are the commensal of the respiratory tract and always in search of opportunity. So, to eradicate them from the respiratory tract, we have to prepare a particular type of vaccine. Now, the capsular antigen and other type of antigen, there are so many variations. About 90 type of serotypes are there and 40 serogroups are there. Especially 3, 6, 19, 9 and 30, 23, these particular serotypes are very dangerous. So, they have isolated, scientists, of 23 polysaccharide antigen from the capsule, and with this 23 polysaccharide antigen, they prepared a polysaccharide 23 vaccine, that is PSB 23. In which group we add? We give vaccine mostly above 65 age, but we prefer giving this vaccine under the 65 group of people, starting from middle age, that is 50 to 65. It is better to vaccinate them with this pneumococcal polysaccharide vaccine of 23 antigen. But the point is same, what I have told before. As it is polysaccharide in nature, the protection is only up to 5 years. So, you have to revaccinate, isn't it? Another vaccine, which is a conjugated vaccine, where we add an adjuvant with this polysaccharide, which is known as CRM190 from corynebacteria, the causative agents of diphtheria. That protein acts as an adjuvant to this polysaccharide antigen. Now, when we add this as an adjuvant, the entire pathway is changed now from B cell stimulation to T cell stimulation now. And whenever the pathway is changed from B cell activation to T cell activation, the immune response is high, the immune protections is high, the vaccine duration is high, and the T cell dependency is unique and memory cells are kept. So, this particular adjuvant of CRM190 also gives the protection to the children. So, less than 2 years of baby or children, they need protection, and the vaccine of choice is this particular conjugated vaccine known as 13 conjugated vaccine or PPV 13. 13 serotypes are added. This is the conjugate vaccine in compared to capsular vaccine. This is highly effective, but this is costly. This is costly. So, very recently, we give 4 doses of this 13 vaccine to all, but India being a poor country, it is very difficult to try this vaccine everywhere, as it is very costly. So, this is all about pneumonia, and a particular population undergoing splenectomy or spleen operation, where this vaccination program is a must. So any patient during your lifetime of splenectomy patient, always advise pneumococcal vaccine. So let's see the slides today. Next. দেখো এটা আমার কাছেই আছে, sorry. So group D streptococci until 1980 comprise of enterococci and non-enterococci group. Those found in the intestinal tract were part of enterococcal group. Both groups possess the common group like D lipoic acid antigen and positive bile esculin hydrolysis test, but differ in many properties. Remember one point, that is how to differentiate between enterococcal and non-enterococcal group by performing 6.5% sodium chloride survival test, isn't it? The characteristics are pneumococcal, enterococcal characteristic, group characteristics are they can survive 6.5% sodium chloride, they can tolerate 40% bile, they can survive 9.6 pH of the intestine, and they can survive 60 degrees centigrade even at up to 30 minutes. So these are the property, because they are intestinal. They have to survive the bile storm. They have to survive the pH variation. They have to survive the temperature and others. That's why their characteristics are classical and absolutely enterococcal in nature. Only enterococcus can survive. Compared to enterococcus and non-enterococcal group, non-enterococcal group includes Streptococcus bovis and equinus. They are more susceptible to antibiotics such as penicillin. Non-enterococcal group, they are more susceptible because enterococcus is resistant, intrinsically resistant. Non-enterococcal group do not grow in presence of 6.5% salt and PYR test negative, pyridinoline test, they are negative. But remember, this particular thing do not grow in presence of 6.5% salt, non-enterococcal group, but they can grow, enterococcus can grow. Less pathogenic to humans and not a part of human intestinal flora, non-enterococcal group, they are not. In humans, they occasionally cause endocarditis associated with colorectal cancer or polyps, occasionally, and penicillin is the drug of choice in non-enterococcal group. In enterococcus, they are non-hemolytic or alpha hemolytic, found as normal flora of human intestine. These all streptococcus are catalase, positive or negative streptococcus. Staphylococcus, they are catalase, positive, and streptococcus, catalase negative, isn't it? So, in a media where streptococcus is grown, how the growth persists? If they have no catalase, the colony will be destroyed by production of H2O2. During the fermentative procedure, H2O2 is produced. So if there is no catalase which splits H2O2 to H2H and hydrogen and oxygen, that will be not there. So in blood agar, how they will grow? What is the mechanism? Catalase নেই তো। Catalase ব্যাকটেরিয়া কি করে? যখন মেটাবলিক প্রসিডিওরে H2O2 তৈরি হয়, তখন H2O2 কে ক্যাটালেস ভেঙে দেয়, ভেঙে হাইড্রোজেন আর অক্সিজেন তৈরি করে। তাহলে যার ক্যাটালেস নেই তার তো কলোনি তৈরি হবে না, টক্সিক ম্যাটেরিয়াল H2O2 জমে থাকবে তো মিডিয়ায়। তাহলে কি করে হবে ব্লাড আগারে? কলোনি হওয়ার কথা না তো, কিন্তু কলোনি তো হয় ব্লাড আগারে, হয়তো কি করে হয়? ব্লাড আগার কি করে তৈরি হয়? শিপ ব্লাড থাকে না, অথবা হিউম্যান ব্লাড থাকে, তো সেই ব্লাড থেকে ক্যাটালেজ পাওয়া যায়। So they utilize it from the sheep blood or human blood. That particular catalase, they utilize it. Clear? তাই গ্রোথটা হয়, তা নইলে গ্রোথ হওয়ার কথা নয়। বেশ, নেক্সট, widespread infection, UTI, meningitis, intra-abdominal infection, endocarditis. Very important is the endocarditis. এখানে দেখো দুটো দুটো করে কক্কাস, ডিপ্লোকক্কাই, এটা ব্যাসিলাই, ডিপ্লোকক্কাই, আবার চেনেও রয়েছে, ইন শর্ট চেন। সো গ্রাম পজিটিভ ডিপ্লোকক্কাই, oval in shape and in short chain. Hemolysis in blood agar, classical, beta hemolysis, all RBCs are destroyed, alpha hemolysis, the greenish tinge, and gamma hemolysis, no hemolysis. The important characteristics, এটা মুখস্থ করতে হবে, এখানে যা আছে সব একদম পরীক্ষায় বলা চাই। কি কি আছে? এটা non-capsulated gram-positive cocci in pair and in short chain, facultative anaerobe, catalase negative, can grow in 6.5% sodium chloride, the characteristic features, can grow in presence of 40% bile, withstand pH up to 9.6, intestine থাকে, সবকিছু বিপদ ঝড়ঝাপটা সামলাতে হয় ওকে, can grow at temperature 10 degree to 40 or 45 degree, and can withstand 60 degrees centigrade for 30 minutes. Two important species, E. faecalis and E. physium. Faecalis টা বেশি পাওয়া যায়, আর physium drug resistant. Opportunistic pathogen, hospital acquired infection. আজকের টপিক mostly cardiovascular catheter, HIV patient, long time hospitalization, infective endocarditis is the result. Catheter associated urinary tract infection, সেখান থেকেও প্রেসিপিটেট করতে পারে। এছাড়া গ্যাস্ট্রোএন্টারাইটিস বা কোনো গ্যাস্ট্রিক সার্জারি, biliary tract infection, pelvic infection, সেখান থেকে ব্লাড স্ট্রিম ইনফেকশন অ্যান্ড সার্জিক্যাল সাইট ইনফেকশন, এগুলোর থেকে এন্টেরোকক্কাস স্প্রেড করতে পারে। এটা অলরেডি বলেছি কি করে ডিফারেন্সিয়েট করবে। মরফোলজিক্যাল পিকচার দেখে নাও কিরকম দেখতে। এখানে নিউমোকক্কাসের কথা এলো। নিউমোকক্কাস কিন্তু ফ্লেম শেপেড, এখানে দেখছো একটা দিক ফ্লেম শেপেড, আর যেটা ফ্ল্যাট এন্ড সেটা একটা অপোজ করে আছে একদিকের সঙ্গে আরেক দিকে, আর একটা ক্যাপসুল হবে। এখানে গ্রাম স্টেনেও ক্যাপসুল দেখতে পাওয়া যায়। এখানে দেখো ল্যান্সিওলেট শেপেড, অ্যান্ড এটা হচ্ছে ইন্ডিয়াইং স্টেন। সমস্তটা স্টেন হয়েছে, ব্যাকটেরিয়া ইটসেলফ স্টেন নিয়েছে, কিন্তু কখনোই স্টেন নেয়নি ক্যাপসুল। ক্যাপসুল রিমেইনস আনস্টেইন, তাই না? দিস স্টেইন ইজ কল্ড নেগেটিভ স্টেইন, তাই না? নেগেটিভ স্টেইন, দিস ইজ নেগেটিভ স্টেইন, ইজ আ শর্ট নোট, অ্যান্ড নিউমোকক্কাসে তোমরা সেটা পাবে। অ্যামিডেজ এনজাইমের জন্য কি হয়, ওই বাইল যখন দিয়ে তোমরা টেস্ট করবে তখন দেখা যায় যে এই ক্যারাম কয়েন শেপেড হয়ে গেছে ব্যাকটেরিয়াটা। ব্যাকটেরিয়ার শেপটা টিপিক্যাল, এটাকে ড্রাফটসম্যান শেপেড বলা হয় বা ক্যারাম কয়েন শেপেড। মাঝখানটা ডিপ্রেসড হয়ে গেছে, তার মানে এদিক থেকে দেখলে এরকম ঢেউ খেলে যাবে, এরকম ক্যারাম কয়েন শেপেড। ক্যারামের যেটা দিয়ে আমরা স্ট্রাইক করি ওই স্ট্রাইকটার মতো মাঝখানে একটা পিঠ থাকে, ওই রকম, ওই জন্য ওটাকে নাম দেওয়া হয়েছে এরকম ক্যারাম কয়েন শেপেড বা ড্রাফটসম্যান শেপেড। ড্রাফটসম্যানে যারা ড্রাফট করে ওরকম একটা পুট টুট দিয়ে করে, ওই পুটের মতো হয়েছে। পাস্তুর সাহেব প্রথম বলেছিলেন এটা নিয়ে, তারপরে অনেকগুলো সেরোটাইপ এসছে, এটা তো তোমরা দেখেছো। ক্যাপসুলার স্টোয়েলিং, এই ফেনোমেননটাকে কোয়েলাং রিয়াকশন, এটা কিছু না, এটা নিউমোকক্কাসের অ্যান্টিবডি নিয়ে, মানে অ্যান্টিজেনের পার্টিকুলার অ্যান্টিজেনের এগেনস্টে যদি তুমি অ্যান্টিবডি নাও, সেটা যদি স্টেনের জায়গায় স্টেন না দিয়ে অ্যান্টিবডিটা দাও স্লাইডে, এক ফোঁটা নিউমোকক্কাসের প্রিপারেশন নিলে তার মধ্যে এক ফোঁটা অ্যান্টিবডি দিলে, দেন ক্যাপসুল সোয়েলিং রিয়াকশন উইল অকার, ক্যাপসুলটা ফুলে যাবে, ইট উইল বি ইজিলি ভিজিবল। এটাকে ভিজিবিলিটি বাড়াবার জন্য একটা প্রসিডিওর উইথ দি পার্টিকুলার সেরোটাইপ এ টিপিক্যাল এ পার্টিকুলার অ্যান্টিবডি ইজ ইউজড। তাহলে অ্যান্টিজেন অ্যান্টিবডি রিয়াকশন হয়েছে, হয়ে ক্যাপসুলটা ফুলে গেছে, এটাকে ক্যাপসুল সোয়েলিং রিয়াকশনস অথবা কোয়েলাং রিয়াকশনস বলে। কোয়েলাং টেস্ট করেছিল, প্রত্যেকে নিজের নামে একটা করে ফেলে, ও করে ফেলেছে কোয়েলাং রিয়াকশনস। অনেক সেরোটাইপ, তার মধ্যে আমি বলেছি ওই 19টা খুব ইম্পর্টেন্ট, 19 অনেকগুলো সেরোটাইপস আছে হাইলি ভিরুলেন্ট, তাই জন্য ভ্যাকসিনে ওকে ইনকর্পোরেট করা হয়েছে। ওটাইটিস মিডিয়া, সাইনুসাইটিস এগুলো হচ্ছে নন ইনভেসিভ, আর এন্ডোকার্ডাইটিস, পেরিটোনাইটিস এগুলো সব ইনভেসিভ ডিজিজ। এর একটা চার্ট করে মনে রাখতে পারো ইনভেসিভ নন ইনভেসিভ কোনগুলো। ক্লিনিক্যাল ফিচার্স এক একটা কোনটায় কি হবে। Epidemiologically, pneumococcal infections, we often suspect that epidemiologically this particular area is suffering from pneumococcal disease because আমরা এটা বুঝতে পারি when an epidemic occurs, especially of respiratory tract infection, and a particular region, that at least 100 patients to 200 patients simultaneously কোন একটা হসপিটালে এসে গেল, সেখানে আমরা পরপর রেসপিরেটরি ট্র্যাক্ট ইনফেকশন দেখছি। তুমি দেখবে কমিউনিটিতে এটা হয়, কমিউনিটিতে দেখবে একজনের রেসপিরেটরি ট্র্যাক্ট ইনফেকশন হয়েছে, পরপর হচ্ছে, সব ছেলেরাই মেয়েদের হয়ে যাচ্ছে, একটা গ্রুপে আছো, হস্টেলে আছো, সেখান থেকে হয়ে যাচ্ছে। সো দিস পার্টিকুলার স্প্রেড, যেখানে বাচ্চারা থাকে একটা গ্রুপে, বাচ্চাদের স্কুলে, সেখানে বাচ্চারা, যেখানে মিলিটারিরা থাকে একসাথে সেখানে, যেখানে আমরা হোস্টেলে থাকি সেখানে, এরকম একটা গ্রুপে পরপর অ্যাটাক হতে থাকে, তখন আমরা সন্দেহ করি যে একটা কিছু এপিডেমিক হচ্ছে, এবং সেখান থেকে আমরা যদি এরকম নিউমোকক্কাস পেয়ে যাই তাহলে সেখানে কিন্তু আমরা আইডেন্টিফাই করতে পারি যে একটা এপিডেমিক্স হচ্ছে নিউমোকক্কাসে। ব্লাড কালচার টেস্ট করা যাবে, এক্সরেতে দেখা যাবে নিউমোনিয়া, কনসলিডেশন তার ফিচার্স পাওয়া যাবে। এখানে দেখো আমরা স্পুটামে পেয়েছি স্যাম্পলে, স্পুটামে এই 4-5টা ক্যাপসুলেটেড স্টেন নেয়নি, আর এটা ভালো আসেনি। এখানে কনসলিডেশন দেখা যাচ্ছে, আর কম্পেনসেটরি এয়ার ট্র্যাপিং বেড়ে গেছে, এদিকে এয়ার ট্র্যাপিং বেড়ে গেছে, ওদিকে এয়ার ট্র্যাপিং বেড়েছে, এখানটা কনসলিডেশন হয়েছে। ওটাইটিস মিডিয়া হয় পাহাড়ে, খুব দেখা যায়, পাহাড়ের বাচ্চাগুলো সবসময় সর্দি কাশিতে ভুগছে, দেখতে পাবে ওদের ওটাইটিস মিডিয়া, কান বন্ধ হয়ে যায়, এবং সে খুব হয়, কানে খুব দুর্গন্ধ হয় এবং সেখান থেকে ইনফেকশন হয়, মিডল ইয়ার ইনফেকশন হয়, ফ্যারিঙ্গোটিম্প্যানিক টিউব ব্লক হয়, ব্লাড, সিএসএফ, জয়েন্ট ফ্লুইডস, প্লুরাল ফ্লুইড সব জায়গা থেকেই তোমরা এটা পেতে পারো। ব্যাকটেরিমিয়া হয়, স্প্রেড, এগুলো নিয়ে আমরা আলোচনা করেছি। নিউমোকক্কাল স্টেনে আর কিছু এখানে বলার নেই, চেস্ট এক্সরে, কালচার তো সব হলো, বায়োকেমিক্যাল টেস্ট হলো, অপটোচিন সেন্সিটিভিটি টেস্ট দেখো একটা ছবি, এখানে অপটোচিন ডিস্ক ইউজ করা হয়েছে, আর তার সেন্সিটিভিটি যদি জোন সাইজ মোর দ্যান 14 মিলিমিটার হয় তবেই ইট উইল বি সেন্সিটিভ টু অপটোকিন অর অপটোচিন। এটা স্ট্রেপ্টোকক্কাস নিউমোনিয়ার ক্ষেত্রে ক্লাসিক্যাল, অন্য স্ট্রেপ্টোকক্কাসের ক্ষেত্রে নয়। দ্য বাইল সলিবিলিটি টেস্ট, এটাও একটা ইম্পর্টেন্ট টেস্ট। দেখো এখানে সলিবল হয়েছে, পরিষ্কার বোঝা যাচ্ছে যে ইট ইজ ক্লিয়ার the Streptococcus pneumoniae is lysed by bile. Inulin fermentation, the particular media required is Heinz's serum sugar media. This media is required to show the sugar fermentation reaction only in case of pneumococcus. Initially, it was all sensitive to penicillin, pneumococcus, but now gradually the drug resistance has emerged. So, drug resistant strains are also seen now. This pneumococcus, can you recognize this picture? This is a picture of Griffith's reaction, transformation. The genetic material is transferred from one avirulent strain to virulent strain. Is it true? Avirulent to virulent. Virulent to avirulent. তাহলে কি ক্যাপসুলেটেড যদি হয়, that particular strain is smooth and non-capsulated strain is rough. So on blood agar media, we will be able to identify that whether this is a transparent or opaque colony. If that is opaque colony, be sure that this is mucoid. Opacity is due to mucoid reaction, and that mucoid reaction is due to capsule. So that particular strain is capsulated. If on the blood agar media, the colony is transparent, then this is non-mucoid. This is avirulent. So এখানে ইঁদুরের রিঅ্যাকশন দেখানো হয়েছিল, গ্রিফিথ দেখিয়েছিলেন, এটা তোমরা পড়েছো, আর বলার কিছু নেই। এই সেই নিউমোকক্কাস যেটা পড়েছিল, সারা পৃথিবীতেই এটা থ্রেট, স্পেশালি 23E, 23F, 23F চারিদিকে ছড়িয়ে পড়েছে, আর 19। তার জন্য ভ্যাকসিন এসছে। ভ্যাকসিন মনে রাখতে গিয়ে বুড়োদের কথা মনে রেখো, আর সমস্ত ডিজিজের কথা মনে রেখো, বাচ্চাদের কথা মনে রেখো। প্রোটেকশনের কথা আমি বলে দিয়েছি, বুঝিয়ে দিয়েছি, কোনটা টি সেল মেডিয়েটেড, কোনটা টি সেল মেডিয়েটেড নয়, ভুল হওয়ার কথা না। এই লাইনটা লেখা থাকলেই নম্বর এসে গেল। পিপিএসবি অ্যান্ড পিসিভির মধ্যে ডিফারেন্সটা তাহলে কি দাঁড়ালো? ডিফারেন্স দাঁড়ালো হচ্ছে পিপিএসবি 23 সেরোটাইপস নেওয়া হয়েছে, আর এখানে অনলি 13 সেরোটাইপস নেওয়া হয়েছে। PPSB, it covers 70 serotypes and cover most serotypes infect children. Children none. It is less immunogenic. It is more immunogenic. It is T cell dependent, independent. This is protein conjugate act as an adjuvant. So it is T cell dependent. Short term immunity, long term immunity, no mucosal immunity, and it provides mucosal immunity effective against carrier strain of nasopharynx. So to eradicate the carrier strain, we have to introduce this PCV13 vaccine. That's why very in recent time, for patients more than 65 of age, we first introduced this PSB13 vaccine, followed by PSB23. So this is all about pneumococcus and enterococcus. বলো, কোনো প্রশ্ন আছে? বোঝা গেছে?
Topic of discussion of today's class is basically MHC molecule, HLA complex, and organ pathology, transplant organ pathology. It's a very difficult topic. Very difficult topic, very important topic for you, especially the HLA system and the basic types of transplant rejection reaction. So have you gone through any chapter related to autoimmunity and hypersensitivity? Have you? Anyone? So do you have at least overview about the T cell function, B cell function, hypersensitivity? Do you have? Okay. So let's start. Have you come through this terminology? MHC molecule, HLA system, HLA class system, etc. Anything? So can you enumerate this full form of MHC? Major histo compatibility system. Complex system. Complex system. The another name of this system is HLA, means human leukocytic antigen. Why this is so important for you, for our pathology purpose? Why? Anyone? Autoimmunity, how it is related to the autoimmunity? Any mutation related to HLA gene causes autoimmunity? Partially correct, partially correct. Basically, why this system is topic of interest? Why? Because basically these are the molecules which binds with protein fragment of antigen. This antigen could be foreign antigen most commonly or self antigen, and after binding with this protein fragment of antigen, it presents to T cell. It presents to T cell. This is the most important character. There is 3 types of complex system related to the HLA. Class 1 system, class 2 and class 3. What is the function of this class 1 type of HLA system molecule? They present this T cell, they present to the CD8 plus T cell. Another name is cytotoxic T cell. Cytotoxic T cell. Class 2 molecule presents the foreign or self antigen after binding with the foreign or self antigen to CD4 plus CD4 plus T cell, that is T helper cell. And class 3 molecules are basically not related to this presenting feature. They are basically complement component like C2, C4 or tissue necrotic factor. One enzyme known as 21 hydroxylase and heat shock protein 70. These are related to the class 3 components of HLA system. So, human leukocytic antigen are that complex system, that specified molecules which binds with the protein fragment of a foreign antigen or self antigen, and after binding that foreign antigen, it presents, these 2 complex present this antigen to T cell for further reaction. So, before presenting to the T cell, this foreign antigen should be processed by either class 1 molecule or class 2 molecule. This is clear up to this portion, is it clear? Everyone? Okay. So, we have to know little bit more about this class 1 and class 2 molecules. Class 1 and class 2 molecules. Why? Because these 2 molecules are intrinsically related to the immunity system of the body. How? Class 1 molecule and class 2 molecule. Okay, before starting this, before we go depth into the class 1 and class 2, this HLA complex proteins are basically coded by a single loci gene, 6p. This is present in the short arm of chromosome 6p. And there is 3 different loci. Okay, 3 different. One loci is coding for class 1 molecule, class 1 molecule, and another loci is coding for class 2, and definitely another loci is coding for class 3. Now, class 1 cluster of molecules are coded by 3 different subloci. Exactly. They are HLA, A, B and C. Class 2 molecule as such, this total loci is D class, and that could be subdivided into, bolo, jano, DP, then DQ and DR. So, HLA A, HLA B and HLA C, these 3 loci will encode for class 1 molecules. DP, HLA DP, HLA DQ and HLA DR, these 3 genetic loci encode for class 2 molecule. You don't have to remember the loci of class 3 molecules. It's not necessary for you. Okay. So, where these class 1 molecules are present? It is present in all nucleated cell. All nucleated cell. But where the class 2 molecules are present? Antigen presenting cells. The binding site of class 1 molecule present in between 2 fragments, alpha 1 and alpha 2. But in case of class 2, alpha 1 and beta 2. These are peptide binding site, peptide binding site. Alpha 1 and between the alpha 1 and alpha 2, all the antigen binds with that site, and between alpha 1, beta 1, this is beta 1, alpha 1 and beta 1, all the antigen binds with the class 2 molecules. Okay, and this all class 1 molecules are present in all type of nucleated cell, but class 2 molecules are usually present in antigen presenting cells. Example dite parbe ekta antigen presenting cell, dendritic cell, again arekta macrophage, modified macrophages, B cells, all these are all antigen presenting. Langerhans cell, okay, follicular dendritic cell, these are all antigen presenting cells. And class 1 molecules actually binds with endogenous proteins or antigen, endogenous antigen. But class 2 molecules usually bind with exogenous antigen. This point is very important. As they are present in all nucleated cell, like in any nucleated cell of body, so they process all kind of endogenous antigen. But in case of class 2 molecules are processing the exogenous antigen because they are present only in case of antigen presenting cell. So, why these HLA molecules are very important to know? Because two important causes. There are basically two important causes. One, before we going to transplant different organ from a donor to recipient, we have to match these chromosomes, that is loci, chromosome 6 এর যে তিনটে লোকাই আছে, যে লোকাই গুলো আছে, there are basically 6 loci are there, HLA A, HLA B, HLA C, HLA DP, DQ and DR. So there are total 6 loci. Ideally, before transplanting any organ, we have to match all 6 loci. Why? Because this is very important to avoid rejection of the transplant. if we don't match the loci of two different donor and recipient, I mean two different body, that will cause initiation of different immunological process, and as a consequence of that immunological process, there will be rejection of transplanted organ. That means that transplanted organs will go into, that will be destroyed by the immune process. The different immune mechanism will activate the immune system, that is lymphocyte, plasma cell, T cell, B cell, production of different type of cytokines, and ultimately they will attack the transplanted organ, and the functionality of transplanted organ will be lost. So this is very important for matching of HLA complex to avoid rejection of transplanted organ. And the second most important, one of the not most important, second is very important point to know the HLA complex is there are certain HLA system, that is the genetic system is associated with certain groups of disease. This is known as genetic susceptibility. Genetic susceptibility of HLA complex to certain diseases. For an example, if any person has HLA B27 positive, they are susceptible to বলতে পারবে কিছু ankylosing spondylitis, AS, ankylosing spondylitis, losing spondylosis। দেখা গিয়েছে almost in 90 to 100% cases of ankylosing spondylosis are positive to HLA B27. So that amount of relative risk is carrying a HLA positive patient for future occurrence of, future development of ankylosing spondylosis. So it will predict the relative risk of particular disease in future, whether it will start its action, it will happen or not. From only the HLA B27, not only the HLA B27, some important groups of HLA system, that molecular typing is very important to know the susceptibility of particular disease. Like in case of type 1 diabetes mellitus, it is HLA DR3, DR4 positive. Usually HLA DR3, DR4 positive patients carrying are susceptible to develop type 1 diabetes mellitus. Like in anterior uveitis, patient with HLA DR4 positive patient are susceptible to develop the anterior uveitis. Like in one connective tissue disease, primary Sjogren syndrome, HLA DR3 positive patient are prone to develop the primary Sjogren syndrome. So there are so many endocrinopathy, channelopathy, musculoskeletal system related disorder, chronic connective tissue disorder. These are all susceptible to, not all, most of the connective tissue disease, channelopathies, endocrinopathies, they are susceptible to develop due to the presence of particular set of loci which is related to the HLA system. So this is very important to predict the relative risk of particular disease from molecular typing of our HLA system. এটুকু ক্লিয়ার হয়েছে? শিওর? ওকে, সো আওয়ার নেক্সট টপিক, এইটুকুতে বলো, এইটুকু যেটুকু পড়ালাম তাতে কারো কোনো প্রবলেম আছে কিনা বলো। So our next topic of discussion is organ transplant pathology. Organ transplant means any organ that could be living organ or could be cadaveric organ. So any living organ or cadaveric organ, when we are separating from a particular individual and it is donating to another individual, this process is known as transplant. So there is two things, one is donor and one is recipient. From donor, an organ is donated into a recipient. So at the time of donating, কি বলেছিলাম, we have to match the HLA system. Ideally, we should match all six loci. We should match because they are the initiating point of molecular, the immune reaction, because they are generating those antigen presenting cells, those all nucleated type of cells which are processing the foreign or self antigen. So we have to match this thing. But practically we are matching three loci. They are HLA-DR, HLA-A and HLA-B. Most importantly, HLA-DR is most important loci to match, then HLA-A and then HLA-B. We should match three loci. One is DR, another is B, another is HLA-A and HLA-B. এটা দেখা গিয়েছে, if we match 2:2:2 HLA-DR, HLA-A, HLA-B genes between recipient and donor, in case of kidney transplant, the survival of that graft, that is donated kidney, mean survival time is 10 years. মানে কি, আমি যদি কমপ্লিটলি ম্যাচ করাই তিনটে লোসাই DR, A and B between donor and recipient, the survival chance of donated kidney is about 10 years. So what are the component which can be transplanted? আমি এটাকে এই জন্যই পিপিটি বানাইনি, বিকজ পিপিটি বানালে তোমরা কনফিউজ হয়ে যাবে। এটা তুমি যদি নিজেও বই পড়ার চেষ্টা করো, ইটস সো টাফ সাবজেক্ট, ইট উইল ডেফিনেটলি কনফিউজ ইউ। যেটুকু বলছি শুধু এটুকু মাথায় যদি বুঝতে পারো, মাথায় রাখার চেষ্টা করো, দ্যাট উইল বি এনাফ ফর ইউর লেভেল। হোয়াট আর দ্য অর্গানস দ্যাট কুড বি ট্রান্সপ্লান্টেড? ওয়ান ইজ ফার্স্ট লার্জেস্ট অর্গান অফ দ্য বডি, skin grafting. Then some hematological organs, bone marrow. এটাকে কি বলা হয়? hematological বসো stem cell transplant, in short known as bone marrow transplant. Okay, and 3 solid organ transplant: kidney, heart, lung, brain, cornea. সবকটা organই almost that are transplanted in a living condition except one that could be even transplanted from cadaveric body, cornea. Cornea can be transplanted from cadaveric body. So what are the types of transplant, you know? What are the types of transplant? One is known as iso transplant or isograft. Isograft, when a organ is transplanted between two identical twins. Identical twins means that could be monozygotic twin or that could be dizygotic twin. If any organ is transplanted between two identical twins, it is known as isograft. Isograft means donation between two identical twins. Next is autograft. Means what? If a organ, part of organ definitely, is transplanted from one side to another in a particular single individual. কোথায় হয় এটা? Skin grafting এ. So example of autograft is skin graft, where a part of organ is transplanted from a original site to another site in a single person, that is within a single individual. The most common type of graft is allograft. What is allograft? When an organ is transplanted from one particular individual to another particular individual belonging from a same species. Belonging in from a same species. মানে এটাই মোস্ট কমনলি কেন বলা হচ্ছে, কারণ এক্ষেত্রেই আমরা DR A and B 3 loci কে ম্যাচ করি and then this organ is transplanted from a particular person to another. Example, most of the examples are belonging to that category like hematopoietic stem cell transplant, solid organ transplant, etc., etc. And another is known as xenograft. When an organ is transplanted from a different species to a different one. যদি আমাদের কোন অ্যানিমালের থেকে কোন অর্গানকে হিউম্যানে ট্রান্সপ্লান্ট করা হয়, দ্যাট উইল বি অ্যান এক্সাম্পল অফ xenograft. এখন xenograft করা হয় না, এনশিয়েন্ট আমলে করা হতো, এখন করা হয় না. It's obsolete nowadays. So these 3 are most important types of grafting reaction. One is isograft, one is autograft, and one is allograft. So usually an organ, if it is transplanted, that works well, but there might be some complications, definitely some complications. And at the beginning of the chapter, I have already mentioned what is the most common type of complication: transplant rejection. Okay, so most important type of complication is transplant rejection. That means rejection of transplant is the most important organ transplant pathology. Other than that, there might be some infection, definitely, might be some secondary malignancy, might be some non-functionality. But আমাদের এই চ্যাপ্টারে আমরা পড়ব what are the types of rejection reaction. Broadly, this rejection reaction can be divided into two major categories. One is host versus graft disease. One is graft versus host disease. Broadly, this category can be divided into two. One is host versus graft disease. Another is graft versus host disease. It is the major category, it is the minor category. Difference ki host versus graft disease type of complications are present in those conditions where the donor, not donor, sorry, where the recipient is immunologically competent. মানে এই ধরনের ট্রান্সপ্ল্যান্ট রিঅ্যাকশনের ক্ষেত্রে যার বডিতে আমরা গ্রাফট বলো বা হিমাটোপয়েটিক স্টেম সেল বলো বা অর্গান ট্রান্সপ্ল্যান্ট করেছি, দ্যাট ইন্ডিভিজুয়াল ইজ ইমিউনোলজিক্যালি কম্পিটেন্ট, হিজ ইমিউন ফাংশন ইজ রিঅ্যাক্টিং. Okay, but in case of graft versus host disease, host or recipient is immunologically crippled. His immune body reaction is not working. The immune reaction has been failed in case of recipient, and in such cases that graft versus host disease can be seen. বুঝতে পারলে পার্থক্যটা? এই ক্যাটাগরিতে রিসিপিয়েন্ট হবে ইমিউনোলজিক্যালি কম্পিটেন্ট, গ্রাফট ভার্সেস হোস্ট ডিজিজের সেকেন্ড ক্যাটাগরিতে রিসিপিয়েন্ট হবে ইমিউনোলজিক্যালি চ্যালেঞ্জড অর ইমিউনোলজিক্যালি ক্রিপলড. ওকে, সো হোয়াট আর দ্য components of this type of transplant reaction, that is rejection reaction. That could be cellular component, that could be non-cellular component. Cellular component are basically two types, खूब easy. One is T cell mediated, one is B cell mediated. B cell mediated means ki antibody, and if it is non-cellular component which is reacting in case of transplant reaction, they are basically cytokines. So these three, that is T cell, antibody and cytokines, they play the major role in transplant reaction. Depending upon their time of action, depending upon the time, this time frame is very important point. Depending upon the time of reaction, this rejection reaction is subdivided into many class. Basically first category কি বলেছিলাম? host versus graft. First category কি বলেছিলাম? host versus graft. That category can be subdivided into three categories. One is hyperacute rejection reaction, hyperacute rejection reaction. Second is acute rejection reaction, and third is chronic graft rejection reaction. So one is hyperacute type, one is acute type, and one is chronic type. Okay, and graft versus host disease is single type. Single mane that could be also divided into graft versus host disease, that is the second category, that could be also divided into acute and chronic type, but the mechanism is same. But here the mechanism of acute type, hyperacute type or chronic type, the mechanism is different. Okay, the mechanism is different. So what are the basic mechanism which are involved in transplant rejection reaction? What are the basic mechanism of transplant rejection reaction? One is acute T cell mediated. Second is B cell or antibody mediated. That also of two type, B cell or antibody mediated are of also two type. One is preformed antibody type, and another is accelerated antibody dependent, accelerated antibody production dependent type. And third, of course, is chronic type. These are the main mechanism. In acute type, this acute type that can be mediated by T cell or B cell. So if it is B cell mediated, then that is basically the reaction which is causing the B cell mediated acute type is accelerated antibody production. But other chronic type and hyperacute type are of different pathology. Ake ashi. So first category is host versus graft disease. First is hyperacute type. কি হয় এতে বোঝো বিষয়টা hyperacute means these reactions are occurring at the time of surgery. যখনই আমরা ট্রান্সপ্ল্যান্ট অপারেশনটা চালাচ্ছি, কিডনি কে আমরা ডোনার থেকে রিসিপিয়েন্টে ট্রান্সপ্ল্যান্ট করতে শুরু করেছি, রিসিপিয়েন্টের বডিতে ট্রান্সপ্ল্যান্ট করতে শুরু করেছি, তখনই দেখা যাবে that reaction is occurring. So already recipient is challenged, immunologically challenged. That means there is already formation of some reactionary mechanism which are causing this hyperacute that is occurring within 5 minutes of operation. বডিতে রিসিপিয়েন্টের বডিতে কোনো অর্গান দেওয়ার 5 মিনিটের মধ্যেই যখন রিয়াকশন হচ্ছে, তার মানে কি there might be some activated machinery already present within the body. So this activated machinery is which kind? This is basically preformed antibody. And how this preformed antibody is present in the donor? There might be prior sensitization. Example, mismatch ABO blood group donation. Mismatch ABO blood group donation. It's very rare, but still it is possible. If there is mismatch ABO blood group donation, there will be the body is prior sensitized, so there is already presence of ki ache preformed antibody. So this is mediated by which mechanism? B cell mediated mechanism. কি করে জানো? This preformed antibody binds with the donor's kidney. Suppose কিডনির মধ্যে যে ভাস্কুলারিটি আছে, প্রচুর ব্লাড ভেসেল আছে, সেই কিডনির ব্লাড ভেসেলের মধ্যে ভাস্কুলার এন্ডোথেলিয়াম আছে। দ্যাট অ্যান্টিজেন অফ ভাস্কুলার এন্ডোথেলিয়াম antibody binds with vascular antigens of vascular endothelium, and this antigen antibody complex deposits in the endothelium, vascular endothelium. So it will initiate the complement fixation and coagulation cascade activation. So these vascular channels of kidney, they ultimately get thrombosed within few minutes, and the kidney become totally non-functional. And this whole thing are occurring within 5 to 10 minutes of donation. So basically it is occurring at the operation table. It is so fast. Hyperacute type is so fast. এটুকু বুঝলে? Hyperacute type. Second type of rejection reaction of host versus graft, broad heading is acute type. কি বলেছিলাম? Acute type. The time frame here is very important. It is weeks to month. Weeks to month. কি হচ্ছে এখানে? That is either mediated by T cell or mediated by B cell. আচ্ছা, একটা কথা বলা হয়নি। হাইপার অ্যাকিউট টাইপে তাহলে কোন ধরনের হাইপার সেন্সিটিভিটি রিঅ্যাক্ট করছে? টাইপ 3 কি? টাইপ 3 তো হচ্ছে ইমিউন ডিপোজিশন, কোনো একটা ব্লাড ভেসেলের মধ্যে দিয়ে গিয়ে একটা অন্য সাইটে গিয়ে মানে ইমিউন কমপ্লেক্স ডিপোজিট করছে। এখানে কি ইমিউন কমপ্লেক্স ডিপোজিট করছে, না অলরেডি অ্যান্টিজেন রয়েছে কোনো একটা সিস্টেমে, সেখানে এসে অ্যান্টিবডি বাইন্ড করছে? Type 2. So in hyperacute type, the type of sensitivity which is active is type 2. It's very not type 3. Type 3 হলে কি হতো? ইমিউন কমপ্লেক্স ডিপোজিট হতো। এখানে ইমিউন কমপ্লেক্স ডিপোজিট হচ্ছে না, ইমিউন কমপ্লেক্স অ্যাট দ্য সাইট অফ রিঅ্যাকশন সেখানে তৈরি হচ্ছে, তাই না? Get my point? Okay. So in acute type, the mechanism is either direct or indirect. Direct means directly B or T cell are damaging. কি হয় বেসিক্যালি? কি হয় অ্যাকিউট টাইপে? একে বলা হয় molecular, not molecular, it is known as self-antigen reaction. That is, when a foreign antigen present within a body, initially the body reacts with the foreign antigen as an self-antigen because there is a mismatch. That mismatch is not there. But gradually, that obliteration of autoimmunity is lost. Obliteration of autoimmunity is lost. Basically, এটাকেই বলা হয়, যা বলতে চাইছিলাম, এটাকে বলা হয় মলিকুলার মিমিক্রি। Donor antigen gradually they are looking like foreign antigen, and against this foreign antigen the immune reaction is getting active. So if directly T cell gets active, that will cause either activation of cytotoxic T cell or T helper cell, activation of T helper cell, or that could be direct activation of the B cell also, like in case of hyperacute type. But hyperacute এর এখানে যে B cell active হচ্ছে, that will be after a few weeks, not within a few minutes. But in indirect type, they are either production of high amount of cytokines or they are type 4 hypersensitivity or known as delayed type of hypersensitivity. Donor antigen is taken as the body is reacting, the recipient body is reacting donor antigen as foreign antigen even after HLA matching. And against this donor antigen, there might be direct action or indirect action. Direct action might be T cell or B cell mediated, and indirect action might be increased production of cytokines, or there could be type 3 hypersensitivity reaction. So basically, if it is B cell mediated, here the mechanism is that immune complex deposition. So here the hypersensitivity is either type 3, or if the type 4 hypersensitivity is active in indirect type, so here the hypersensitivity reaction which is occurring in type acute type is type 4. So either type 3 or type 4 type of hypersensitivity reaction is occurring in case of acute host versus graft transplant rejection. বোঝা গেল? Chronic. Now the thing is chronic. Chronic is easier. Why? Because chronic means again the donor's antigen is taken as a foreign antigen, and only type 4 hypersensitivity reaction is occurring. Basically it is seen in case of kidney, and only the vascular channels mostly affected. That is why it is known as chronic rejection vasculopathy. The mechanism is same. It is only T cell type, that is helper T cell type, type 4 hypersensitivity. All the blood vessels are reacting, so there will be intimal fibrosis and ischemia. Ki hoy? Basically there will be intimal fibrosis as a reaction. Intimal fibrosis তোমরা সবাই পড়েছো type 4 hypersensitivity. Basically it's a basically a long granulomatous inflammation. There might be granuloma. Basically it's a long inflammation, chronic inflammation. So as a chronic inflammation, as a sequelae, there will be some granulation tissue formation. As a part of granulation tissue, there will be some fibrosis, and here the site of fibrosis is intimal layer, so it is known as intimal fibrosis. And that intimal fibrosis ultimately causes narrowing of the blood vessels, so there will be renal ischemia. So the whole kidney ultimately becomes pale, flaccid and non-functional. So this whole reaction is known as chronic rejection vasculopathy. Type 4 hypersensitivity plays the major role in this type of host versus graft rejection reaction. Host versus graft rejection reaction. এই তিনটে পয়েন্ট তিন টাইপে বুঝতে কিছু অসুবিধা হয়েছে? কি হলো তাহলে অ্যাকিউট টাইপে কি হলো? প্রিফর্মড অ্যান্টিবডি ছিল, দে বাইন্ডস উইথ দ্য endothelium antigen. Hyperacute preformed antibody, they binds with the antigen of vascular endothelium, so initiate the coagulation cascade. There will be formation of fibrosis within a few minutes, and that causes key total graft failure. Acute type, they usually after few weeks to few months, and chronic type is usually after few years, even 1, 2, 3, after few years. So in acute type, that could be direct or indirect mechanism. Direct mechanism is T cell mediated or B cell mediated. If it is B cell mediated, then type 3 hypersensitivity plays the most important role. And if it is indirect type, then there might be high amount of cytokines formation, or that could be delayed type of hypersensitivity reaction. Here, the donor antigen is taken as a foreign antigen, and against that foreign antigen, the body is reacting. The same mechanism also present in case of type 4, but the main difference between acute and chronic is there is only type 4 hypersensitivity. So as a reaction, there will be only intimal fibrosis. The vascular channels of the solid organs are mostly reacting, and there will be intimal fibrosis, narrowing of the blood vessel, renal ischemia, and the organ become pale, etc. And that second category of rejection reaction. Second category is a bit tricky category. This category is graft versus host. This category only seen in case of bone marrow transplant. কি বলেছিলাম এই ক্যাটাগরি হতে গেলে কি শর্ত হতে হবে? Which one? Donor or host or recipient? Recipient যে আছে তার immunologically they are nil. Donor যে আছে সে immunologically অ্যাক্টিভ। এবার কি হতে পারে ভাবো তো, কি হতে পারে? This active lymphocyte T cell or B cell from donor attacks the antigen of recipient. বুঝলে? As the donor is immunologically competent, means all the immunological reactionary mechanism are active. So bone marrow transplant হয়েছে রিসিপিয়েন্টে, বোন ম্যারো যেটা ডোনার থেকে রিসিপিয়েন্টে গিয়েছে সেখানে অ্যাক্টিভ টি আর বি সেল আছে, তাই তো? and they are reacting with antigen of recipient. Here not the antibody, that is the T cell or B cell of recipient is acting over the bone marrow of donor or donated bone marrow. একই ব্যাপার হলো donated bone marrow. Why? Because it is not active, it's failed. There is complete absence of immunologically active T or B cell in case of recipient. So here the thing is bone marrow is transplanted in the recipient, and that active T or B cell of that transplanted bone marrow, they are reacting with the antigen of recipient. এইটুকু বুঝেছো? Sure? That is why it is known as graft versus host. Grafter যে antibody, they are reacting with the host antigen. তিনটে অর্গান এটাকে ট্রায়াড বলা হয়। 3 organs are involved. One is GIT, one is liver, one is skin. GIT, as a consequence of graft versus host disease in a GIT, we usually see diarrhea in liver, vanishing bile duct syndrome, which is clinically present as jaundice. Clinical feature will be jaundice, and in skin there will be presence of purpuric spot or rashes. This triad will be there in case of graft versus host disease after the bone marrow transplant, and that triad consists of diarrhea, vanishing bile duct syndrome, the clinical manifestation will be jaundice, and purpuric spot or rashes over the skin. That is in nutshell about organ transplant pathology and HLA molecule. It's very tough, I know, it's very tough, but that amount of knowledge should be there for you, for your level. So any question?